Let's start with part 3 of cardiac surgery, congenital heart disease. Introduction. Congenital heart diseases are abnormalities of cardiac structure that are present from birth. Such abnormalities in the development of heart typically arises in the 3rd to 8th week of gestation. The first operation for congenital heart disease was the ligation of patent ductus arteriosus by Gross in 1938. With the development of neonatal cardiopulmonary bypass, improved methods of myocardial protection and microsurgical techniques, an increasing number of corrective and palliative procedures are possible. Development of the heart and fetal circulation and circulatory changes at birth. By 12 weeks of fetal life, the primitive vascular tube is fully developed. The fetal circulation differs from that of the adult in that the right and left ventricles pump blood in parallel rather than series. Such an arrangement allows the heart and head to receive more highly oxygenated blood. In the fetus, this is possible because of the presence of 3 structural shunts: the ductus venosus, the foramen ovale, and the ductus arteriosus. Soon after the birth, pulmonary vascular resistance falls because of the action of breathing and the resulting pulmonary vasodilatation. In addition, within 30 minutes of delivery, the ductus arteriosus characteristics in response to an increase in blood oxygen levels. The result is a reversal of the pulmonary systemic pressure gradient and termination of blood flow from the pulmonary artery into the aorta. After the birth, the act of cutting and tying the umbilical cord stops venous blood flow from the placenta. This lowers the pressure in the inferior vena cava, and with the fall in the pulmonary vascular resistance, right atrial pressure falls. The result is closure of foramen ovale. The abolition of venous return from the placenta also causes the ductus venosus to close. The closure of the fetal circulatory shunts in the few hours following birth is functional, with complete structural closure typically taking several months. In 20% of adults, the structural closure of the foramen ovale remains incomplete, but is of no cardiovascular significance. Abnormalities of cardiac structure may arise from persistence of normal fetal channels like patent ductus arteriosus, patent foramen ovale, or failure of septation, that is ASD, VSD, and tetralogy of Fallot, stenosis, intracardiac, supravalvular, valvular, infravalvular, or extracardiac coarctation of aorta, atresia, or abnormal corrections as we see in TGV and total anomalous venous drainage. Fetal echocardiography is now sufficiently sensitive to detect intracardiac lesions in the second trimester. Incidence. Congenital heart disease is the most common congenital abnormality in the UK. The incidence of significant cardiac abnormalities is 8 cases per 1,000 live births. Many spontaneous abortions or stillbirths have cardiac malformations or chromosomal abnormalities associated with structural heart defects. In neonates and children with congenital heart disease, 15% will have more than one cardiac abnormality and 15% will have another cardiac abnormality, extra cardiac abnormality. Etiology. There is often no obvious etiology. Most abnormalities appear to be multifactorial with both genetic and environmental influences. There are well recognized associations. Summary 54.13. Recognized associations with congenital heart disease. So, maternal or environmental factors: infection, rubella, disease SLE, DM, drugs and medications, alcohol abuse, warfarin, phenytoin, lithium. Genetic factors include the single gene defects like in Marfan's, Noonan, and Holt-Oram syndromes. Chromosomal defects: trisomy 21 Down syndrome, trisomy 18 Edwards syndrome, trisomy 13 Patau syndrome and Turner syndrome. Deletions as in DeGeorge and Williams syndromes. Diagnosis. Occasionally an antenatal diagnosis is possible with severe congenital heart disease detected in utero at 16 to 18 weeks. If an infant is suspected of having a congenital heart disease, a diagnostic evaluation begins with an accurate history from the parents and specific questions about maternal health and drug intake during pregnancy. A detailed family history is important because some defects are familial. Clinical examination may reveal a murmur, evidence of heart failure, failure to thrive, and cyanosis. In addition, congenital heart disease can present with hypertension and arrhythmia, evidence of polycythemia, or a thromboembolic event. Investigation is much the same as for the adult patient, and with fetal echocardiography available, cardiac catheterization is now avoided whenever possible. Here we can see the fetal circulation and the 3 shunts which help carry out the fetal circulation: the foramen ovale, the ductus venosus, and the ductus arteriosus. Classification. The congenital heart disease can be broadly classified according to the presence or absence of cyanosis. Although the distinction is not always clear-cut, the presence of central cyanosis, blueness of the trunk, and mucous membranes results from the levels of deoxygenated hemoglobin of more than 3 to 5 gram per deciliter in the arterial circulation. Cyanotic congenital heart diseases makes up 1/3 of cases and are usually more complex. Although they do include simple defects, cyanotic congenital cardiac lesions can involve a right to left shunt resulting in decreased pulmonary blood flow. Many of these lesions consist of a septal defect in conjunction with a right-sided obstructive lesion, producing an obligatory right to left shunt. The most common cause of this is tetralogy of Fallot, parallel systemic and pulmonary blood flow rather than in series. If there is no mixing, this is incompatible with life. So typically neonates have a patent foramen ovale or VST that allows some mixing of the two circulations at this level. The most common example of this is transposition of great vessels. Then defects in the connections of the hearts in which there is mixing of the systemic and the pulmonary flows. An example of such a complex lesion is total anomalous pulmonary venous drainage. And second, now we've seen the cyanotic congenital heart disease. Now acyanotic congenital heart disease. These represent the other 2/3 of the cases and are usually less complex. Such effects result in an increase in the work imposed on the heart because of either a left to right shunt with increased pulmonary blood flow, which causes an increase in volume work of the heart. Example PDA, VST and AST. Obstruction of the blood flow across the heart valve on the left side of the heart, such as aortic stenosis or in the aorta itself, as occurs with coarctation of aorta, leading to an increase in pressure and work of the heart. Typically, acyanotic congenital heart disease presents as heart failure in infancy because of pulmonary congestion caused by increased pulmonary blood flow or increased pulmonary venous pressure resulting from an obstructive lesion. The common acyanotic cardiac defects can also present as murmur in infancy or later. Now we will see individual cyanotic congenital heart disease, starting with tetralogy of Fallot. This is the most common cyanotic congenital heart disease, found in children surviving to 1 year and accounts for about 4 to 6% of all congenital heart diseases. The 4 intracardiac lesions originally described were VSD, overriding of aorta, pulmonary, typically infundibular or subvalvular stenosis, right ventricle hypertrophy. Clinically, there may be no signs initially, but as pulmonary stenosis progresses, cyanosis typically develops within the first year of life. Squatting is an adaptation by the child in hypoxic spells. This increases systemic vascular resistance and the venous flow to the heart, and consequently blood is diverted into the pulmonary circulation with increased oxygenation. Lethargy and tiredness are also common. Now we'll see the Fallot's tetralogy. First, there is narrowing of the pulmonary valve, and because of this, there is a increase in work of the right ventricle, which, because of the increased works, gets hypertrophy, and because of its hypertrophy, it gets diverted and overrides the aorta. That's part 3, displacement of aorta over the ventricular septal defect, and last is the ventricular septal defect opening between the left and the right ventricles. Classically, the chest radiograph demonstrates a boot-shaped heart with poorly developed lung vasculature. The diagnosis is confirmed with echocardiography. Surgery to correct tetralogy is the mainstay of treatment and is usually carried out at 4 to 6 months of age when possible. The repair is achieved using a patch to close the VSD and resection of the obstructing section of the infundibular septum. The results of surgery are good, with a late survival rate of 95% at 5 to 10 years following correction of tetralogy, and a operative mortality rate for a pair of between 5 to 10%, and an incidence of reoperation following tetralogy repair is 5 to 10%. Transposition of great vessels. The condition first described by Morgagni is the second most common cyanotic congenital heart disease and is the most common cause of cyanosis from a congenital cardiac defect discovered in the newborn period. Transposition of great vessels results from an abnormal development and typically occurs when the aorta arises from the right ventricle and the pulmonary artery from the left ventricle. The resulting transposition causes the pulmonary and the systemic circulations to run in parallel rather than in series, so that oxygenated pulmonary venous blood returns to the lungs and desaturated systemic venous blood is pumped around the body. The situation is incompatible with life, and mixing of the blood must occur through the associated shunts such as patent foramen ovale or the associated VST. The most obvious presentation is severe central cyanosis occurring in the first 48 hours of life. However, if there is a large ASD or VSD, there may be minimal cyanosis initially. Typically, progress is poor, and as pulmonary vascular resistance declines in the neonatal period, high pulmonary flow develops with cardiac enlargement and left ventricular failure. The chest radiograph shows pulmonary plethora with the heart having an egg on its side appearance with a small pedicle, aorta in front of pulmonary artery. Cardiac echocardiography is sufficient to confirm the diagnosis and delineate the anatomy. Many infants will die without treatment within 1 month of birth. Initial stabilization can be achieved by performing percutaneous balloon septostomy to increase the systemic arterial oxygen saturation. Alternatively, intravenous prostaglandins can be administered to keep the PDA open and increase systemic pulmonary shunting. Arterial switch repair is currently the standard operation and is typically carried out within the first few weeks of life. Long-term outcomes of the operation are excellent and many patients achieve good exercise tolerance. However, some patients will require reoperation for neopulmonary stenosis. Total anomalous pulmonary venous drainage. Total anomalous pulmonary venous drainage accounts for only 1 to 2% of congenital heart disease. Okay, first, before that, we'll see the transposition of great vessels. In this, we can see the right ventricle opens and supplies the aorta to the body again, and the left ventricle opens into the pulmonary artery. Now we'll start with total anomalous pulmonary venous drainage. Total anomalous pulmonary venous drainage accounts for only 1 to 2% of congenital heart disease. In this condition, the pulmonary venous drainage has become disconnected from the left atrium and drains into the systemic venous circulation at some other point, inferior vena cava, superior vena cava, coronary sinus, or directly into the right atrium. Typically, TAPVD presents after the first week of life with cyanosis that is mild to moderate depending on pulmonary flow. Infants with high pulmonary flow develop cardiac failure, recurrent chest infections, failure to thrive, and feeding difficulties. If high pulmonary flow is associated with a large AST, cyanosis is often minimal and the lesion is tolerated well. If there is additional venous obstruction, cyanosis present at birth with dyspnea and pulmonary edema. Echocardiography and cardiac pulmonary angiography are necessary to confirm the diagnosis and establish the location of the anomalous drainage. The surgical principle is to re-establish the pulmonary venous drainage into the left atrium. The exact operative technique depends on the anatomy and type of TAPVD. The long-term results for survivors of the operation are generally good. Late death following repair is uncommon, but when it occurs, it is often caused by interval fibroplasia of the pulmonary veins away from the anastomosis. Eisenmenger syndrome. Eisenmenger syndrome is becoming less common as corrective surgery is undertaken increasingly early and fewer patients develop a fixed increase in their pulmonary vascular resistance. It occurs following the reversal of a left to right shunt across a previous left to right shunt, which as with an ASD or VSD. These congenital anomalies cause an increase in flow and higher right-sided pressures, which lead to compensatory right ventricular hypertrophy and a subsequent rise in pulmonary artery pressure. Increasing pulmonary hypertension leads to equalization of pressures either side of the shunt, but at some point the right-sided pressure will exceed those on the left side, resulting in shunt reversal and desaturated blood entering to the left side of the circulation. Cyanosis and dyspnea are the most common clinical features. Closure of the shunt is contraindicated if pulmonary hypertension is irreversible because of the right to left shunt now serves to decompress the pulmonary circulation. Acyanotic congenital heart disease, patent ductus arteriosus. The ductus arteriosus, a normal fetal communication, facilitates the transfer of oxygenated blood from the pulmonary artery to the aorta, shunting blood away from the lungs. Normally, functional closure of the ductus occurs within a few hours of birth. It is abnormal if it persists beyond the neonatal period. The ductus closes in response to an increase in peripheral oxygen saturation and a drop in the resistance of the pulmonary circulation as the lung expands. This causes the ductal tissue to contract through a prostaglandin inhibition mechanism. A cyclooxygenase inhibitor, indomethacin, may be used therapeutically to close the ducts in the first few weeks of life. In premature babies, the ductus is more likely to remain patent for a longer or permanently. In the isolated case of PDA, there is a left to right shunt of blood resulting in a high pulmonary blood flow. Small shunts usually cause few symptoms and signs apart from the continuous machinery murmur in the left second intercostal space. Larger ducts can cause cardiac failure and can uncommonly lead to shunt reversal with cyanosis and clubbing. The diagnosis is best confirmed by echocardiography with color flow Doppler imaging. After 6 months of age, spontaneous closure of a PDA is rare. Most should be closed by preschool age regardless of the absence of symptoms if the risk of infective endocarditis, developing left ventricular failure, or rarely Eisenmenger syndromes are to be avoided. In the adult, surgical treatment is indicated if there is a persistent left to right shunt, even in the presence of reversible pulmonary hypertension. In the premature infant, if medical treatment to close the ductus is unsuccessful, the PDA may be treated by interventional cardiology using an umbrella or coiled duct occlusion device inserted percutaneously. If the PDA is very large or the patient very small, surgical closure via left thoracostomy is preferred. This can be accomplished by either ligation or division of the PDA. The operative mortality rate is low and outcome generally very good. Coarctation of the aorta. This accounts for 6 to 7% of congenital heart disease and is defined as a hemodynamically significant narrowing of the aorta, usually in the descending aorta just distal to the left subclavian artery, around the area of the ductus arteriosus. The coarctation typically puts a pressure load on the left ventricle, which can ultimately fail. The upper body is well perfused, but the lower body, including the kidneys, are poorly perfused, leading to fluid overload, excess renin secretion, and acidosis. Coarctation usually affects boys, and if it occurs in girls, it is suggestive of Turner syndrome. We'll look at the coarctation of aorta over here. Coarctation causes severe obstruction of the blood flow in the descending thoracic aorta. The descending aorta and its branches are perfused by collateral channels from the axillary and the intercostal arteries through the intercostal into the internal thoracic arteries through the intercostal arteries. In the neonatal period, coarctation, often referred to as infantile or preductal coarctation, presents with symptoms of heart failure. The child may appear well in the first few days of life, but the coarctation is bypassed by the ductus arteriosus and oxygenated blood reaches the entire systemic circulation. As the ductus closes, the child becomes progressively more unwell. In adult type coarctation, which is often juxtaductal or slightly postductal, obstruction is gradual with complications developing in adolescence or early adulthood. Hypertension is a common presenting problem in older children, often upper body hypertension only with development of enormous collateral vessels that may cause rib notching and flow murmurs over the scapula. Other symptoms include prominent pulsation in the neck, tired legs, and intermittent claudication on exercise. Clinical examination of the pulses may demonstrate a radiofemoral delay and a murmur that is continuous and heard best over the thoracic spine or below the left clavicle. The chest radiograph classically demonstrates rib notching because of dilated posterior intercostal vessels. The heart is usually of normal size in the older child and shows a classical 3 sign replacing the typical aortic knuckle. The upper part of the 3 sign is the dilated left subclavian. The middle part is the narrowing at the coarctation site, and the lower part is the post-stenotic dilatation of the descending aorta. Echocardiography is diagnostic. Infant coarctation typically presents with cardiac failure, often requiring vigorous medical management, including the administration of prostaglandins to reopen ductus and general resuscitation before corrective surgery. Definitive treatment is usually surgical repair via a left thoracotomy. Coarctation presenting in the child or later typically requires surgical repair, as most patients die before the age of 40 years because of the associated complications. Percutaneous stenting is currently the standard treatment for adults with isolated coarctation. Without correction, the majority of deaths are caused by heart failure, infective endocarditis, rupture of aorta, or hemorrhagic stroke. The preoperative hypertension cannot resolve despite surgical repair. Atrial septal defect. An ASD is a defect in the septum between the left and the right atria, leading to a left to right shunt, the significance of which is determined by the size of the defect and the relative complication of the ventricles and the relative compliance of the ventricles. The development of the atrial septum is complex, and abnormalities of development lead to 3 commonly recognized ASDs. The most common type is the ostium secundum ASD. The anomaly is caused by failure of the septum primum to develop, leading to incomplete coverage of the ostium secundum. These defects are usually asymptomatic in childhood, with symptoms developing insidiously, typically presenting in the middle age with congestive cardiac failure secondary to pulmonary hypertension or with atrial arrhythmias. In ostium primum ASD, the anomaly is a form of partial atrioventricular canal defect or endocardial cushion defect. The abnormalities are confined to the atrial septum and are caused by the endocardial cushions failing to develop and so close the ostium primum part of the interatrial septum. The defect is associated with abnormalities of the mitral valve leading to mitral regurgitation. There is a relatively high incidence of this abnormality in trisomy 21 Down syndrome. Typically, the primum defect presents earlier than ostium secundum in childhood, with dyspnea, recurrent chest infections, and if pulmonary hypertension develops, cyanosis. So we've seen that most common type of ASD is ostium secundum, but in Down syndrome, trisomy 21, most common ASD is ostium primum. Now we'll look at figure 54.25. Atrial septal defect viewed from the right side. The fossa ovalis is usually the reference point. The most common defect is in the area and is called the fossa ovalis or ostium secundum. A defect near the atrioventricular junction may appear as a part of the spectrum of the atrioventricular septal defects. If the defect is near the entry of the superior vena cava, It is commonly associated with anomalies of the venous drainage into the atria. Sinus venosus ASD is a rare defect and is the result of the failure of partition of the pulmonary and the systemic venous circulations. These defects are most commonly located high in the atrial septum at the junction of the superior vena cava and the right atrium. They are frequently associated with anomalous pulmonary venous drainage, with right superior pulmonary veins draining into the superior vena cava or right atrium directly. Now, summary box 54.14, atrial septal defects. Common defects: ostium secundum, fossa ovalis defect, approximately 70% of ASDs. Ostium primum, atrioventricular septal defect, approximately 20% of ASDs. Sinus venosus defect, often associated with anomalous pulmonary venous drainage, approximately 10% of ASDs. Patent foramen oval, common in isolation, usually no left to right shunt, not strictly an ASD. Rarer defects: inferior vena cava defects, a low sinus venosus defect, and may allow shunting of blood into the left atrium. Coronary sinus septal defect, also known as unroofed coronary sinus, with the left superior vena cava draining into the left atrium as part of a more complex lesion. Closure is performed during the first decade of life, even in the absence of symptoms, to avoid late onset right ventricular failure, endocarditis, and paradoxical emboli. In adults, closure is still appropriate for symptomatic improvement and avoidance of complications. The traditional method of closure involves open heart surgery with cardiopulmonary bypass and closure of the defect, either directly with sutures or with most secundum defects, or if the defect is large, using a pericardial or a synthetic patch. Closure of the small to moderate ASDs using percutaneous catheter delivered devices in the cardiology catheter laboratory is increasingly common. Primum atrioventricular defect repairs may require additional mitral valve repair. The operative mortality rate for isolated atrioventricular defect repair is less than 1% with an excellent prognosis. Surgical correction of complete atrioventricular canal defects with closure of the ASD and ventricular septal components and mitral valve repair is possible, but with a higher surgical mortality. Ventricular septal defects: a VSD is a defect in the interventricular septum that allows a left to right shunting of blood. VSDs account for 20 to 30% of congenital heart disease and affect approximately 2 in 1,000 live births. They may occur in isolation or as a part of a more complex set of cardiac abnormalities. Example: tetralogy of Fallot, complete atrioventricular canal defect. 4 major anatomical types of VSD are described based on the anatomical subsections of the interventricular septum. Types of ventricular septal defects: perimembranous defects, also called as the conoventricular VSD, the most common defect, 70 to 80%, usually located within the membranous septum and may extend to the tricuspid valve, annulus, or base of the aortic valve. Muscular defect, also known as the trabecular VSD, occurs in 10% of cases and is located in the membranous septum and often multiple. Atrioventricular defect, also called the atrioventricular canal type or inlet defect, occurs in 5% of cases and is located in the atrioventricular canal beneath the tricuspid valve. Subarterial defect, also called the outlet or subarterial VSD, occurs in 5 to 10% of cases and lies within the conal septum immediately beneath the pulmonary valve annulus. This is the diagram showing the ventricular septal defect from right. There is the subarterial on the top, then perimembranous, atrioventricular, and finally the muscular below. The VSD permits left to right shunt at the ventricular level with subsequent right ventricular volume overload and increasing pulmonary blood flow. This may lead to progressive pulmonary edema and congestive cardiac failure. Persistently elevated pulmonary blood flow and pulmonary vascular resistance also lead to irreversible pulmonary hypertension. They may eventually result in reversal of flow across the defect and Eisenmenger syndrome. The clinical presentation reflects the magnitude of left to right shunt, which in turn depends on the size of the VSD and the pulmonary and systemic vascular resistances. Small defect may also may close or cause little systemic disturbances. Maladie de Rocher. Infants are asymptomatic with normal development. In the first 5 years, up to 30 to 50% of VSDs close spontaneously. Clinically, a loud pansystolic murmur can be detected in the left sternal border because of high pressure flow between the ventricles. Large defects typically present with congestive cardiac failure in the first 2 months of life. Because of the size of the VSD, ventricular pressures are equalized and often only a soft systolic murmur is detected. If left untreated, pulmonary hypertensive changes start from about 1 year of age. Eisenmenger syndrome, secondary to shunt reversal in such cases, may become evident in the second decade of life. Echocardiography confirms the diagnosis and can estimate the degree of shunting across the defect. Cardiac catheterization can quantify the various pressures within the cardiac chambers and so assess the degree of pulmonary hypertension, as well as demonstrating a setup in the oxygen saturation between the left and the right ventricles. Generally, surgical closure is indicated for large defects when there is failure to respond to medical therapy for left to right shunts of more than 2:1, when there are signs of increasing pulmonary vascular resistance and in the presence of complications of VSD. These include aortic regurgitation, which occurs in about 5% of defects, infundibular stenosis, which tend to be progressive and lead to shunt reversal, and infective endocarditis, often presenting with pneumonia or pleurisy as the infected emboli in a VSD, with a typical left to right shunt flows into the pulmonary circulation. Thoracic aorta. The most common pathologies affecting thoracic aorta are the aneurysm formation and the aortic dissection. We'll start with thoracic aortic aneurysms. A true aneurysm is the localized dilatation of a blood vessel involving all the layers of the vessel, whereas a false aneurysm has compressed supporting tissue as in its wall and is usually the result of a defect in the vessel intima from trauma, dissection, or previous surgery. Aneurysms are described as fusiform when the whole circumference is affected, or saccular when only a part of the circumference is involved. Aortic aneurysms can develop anywhere along its length, but thoracic aortic aneurysms, including those that extend into the upper abdomen, thoracoabdominal aneurysms, account for 25%, typically occurring in men in the 5th to 7th decade or younger in those with connective tissue disorders. Etiology. The most common etiology is atherosclerosis, but connective tissue disorders account for many aneurysms in the aortic root and descending aorta now that tertiary syphilis is rare. Marfan syndrome is associated with cystic medial degeneration involving the vessel wall and causes widening of the proximal aorta and aortic root, leading to aortic valve insufficiency. Other disorders associated with aneurysm formation and dissection include Ehlers-Danlos syndrome and osteogenesis imperfecta. Trauma, typically following the blunt chest injury, can lead to aneurysm formation, usually involving the descending aorta. However, these are usually false aneurysms containing hematoma from injury to the aortic vessel wall. Clinical features. Many aneurysms are asymptomatic and are discovered incidentally on routine chest radiographs. Others present as a space-occupying lesion in the thorax with pain caused by pressure on adjacent structures, vertebra, hoarseness, left laryngeal nerve, dysphagia esophagus, and respiratory symptoms, left main bronchus. Aortic root aneurysms may lead to dilatation of the aortic root annulus and aortic regurgitation. Rupture can lead to cardiac tamponade or hemorrhage into the left pleural space, leading to dyspnea, and if the tracheobronchial airway or esophagus is involved, hemoptysis or hematemesis respectively. Investigations. The diagnosis is confirmed by CT or MRI. Arteriography is not necessary for diagnosis but is often required to demonstrate the relation of the arch vessels to the aneurysm. Indications for surgery. Without treatment, the aneurysm is likely to expand and ultimately rupture. Important factors to consider when planning treatment are age, comorbidity, and coexisting coronary disease. In ascending aneurysm, the presence of progressive aortic valve insufficiency is an important indication for surgery. In other indications of this group, including Marfan-related aneurysms, are diameter of 4.5 to 5 cm and the presence of symptoms. Whereas in descending aneurysms, indications for surgery include symptoms, acute enlargement, and a diameter of approximately 6 cm. Surgical options. The approach adopted for surgical treatment depends on the location of the aneurysm, but typically involves a median sternotomy, cardiopulmonary bypass, and cooling the patient to 18 degrees Celsius before cross-clamping the aorta above the aneurysm. So in this diagram, 54.27, a large thoracic aortic aneurysm we can see, and we can see the green arrow where the cross-clamping is being done above the aneurysm. If the aortic root is involved, the aorta together with its annulus and valve is resected and a composite graft is sutured to the aortic root. The circulation is arrested, and after removal of the aortic cross clamp, the distal anastomosis is completed. The coronary ostia require reimplantation into the graft, that's the Bental's operation. If the ascending aorta is involved, it is resected and replaced with a tube graft. For aortic arch aneurysms, surgery of this section of the aorta is a formidable undertaking because the cerebral and subclavian vessels have to be anastomosed to the graft either separately or en bloc. Typically, it involves a period of circulatory arrest and some form of cerebral protection. Excision of a descending aortic aneurysm is with graft replacement under cardiopulmonary bypass with exposure via left thoracotomy or with a heparin bonded shunt. Increasingly, thoracic aneurysm at the aortic arch or more distal are repaired using a percutaneous approach via the femoral artery with insertion of an endovascular stent under radiological guidance. The most recent guidelines support the use of endovascular techniques over open surgical operations. Surgical outcome: the operative mortality rate is variable depending on the location and type of repair required, but electively is between 5 to 15%, and emergency repair has a considerable higher operative mortality rate. Long-term survival depends on the underlying pathology, but for ascending aneurysm repairs, the 5-year survival rate is approximately 65%. The major complications of descending aneurysm repairs include paraplegia, renal failure, and ventricular dysfunction. Now coming to the second problem, aortic dissection. This occurs when a defect or flap occurs in the intima of the aorta, resulting in blood tracking into the aortic tissues, splitting the medial layer and creating a false lumen. It most commonly occurs in the ascending aorta, or less often. Okay, before that, we'll see summary box 54.16. Predisposing factors for this aortic dissection: age, hypertension, Marfan syndrome, pregnancy, other connective tissue disorders, for example, Ehlers-Danlos syndrome, giant cell arteritis, SLE, coarctation of the aorta, Turner or Noonan syndrome, aortic cannulation site, that's aortogenic. Okay, it most commonly occurs in the ascending aorta, or less often just distal to the left subclavian artery. It is more common in men, typically those aged between 50 to 70 years, and in Afro-Caribbean patients. Etiology: it usually occurs as spontaneous or sporadic event, although very often a history of hypertension is noted. Other important associations include Marfan syndrome and pregnancy. Clinical features: the presentation is often a tearing intrascapular pain, not unlike the pain of myocardial ischemia, and it may be difficult to distinguish between the two. The extent of arterial dissection may produce widespread symptoms and signs. The dissection can extend distally down the aorta to involve the renal arteries, renal pain and renal failure, the mesenteric arteries, abdominal pain and bowel ischemia, the spinal arteries, paraplegia, the iliac arteries, leg pain, pallor, loss or reduced pulses, and limb ischemia. The dissection may track proximally to involve the head and neck vessels, symptoms and signs of a stroke or a transient ischemic attack, the coronary vessels, the aortic root, aortic regurgitation. The dissection may also result in aortic wall rupture into the pericardium, cardiac tamponade, or mediastinum, left hemothorax. Now classification: this is the figure for the classification of aortic dissection. We can see there are two types of classification. One is the DBKs and the other is Stanford. DBK says DBK 1, 2 and 3. DBK 1 says ascending and descending aorta both are involved. In DBK 2, ascending is only involved, and DBK 3 only descending involved. Stanford makes a simplified version where he says both 1 and 2 of DBK is together known as type A, in which aortic ascending aorta is involved, whereas type B is where ascending aorta is not involved for Stanford. So classification: there are two classifications, both of which are limited in their application but widely used. The DBK's classification is based on the pattern of dissection, whereas the Stanford classification is based on whether the ascending aorta is involved or not. Investigation: the diagnosis is suspected based on the clinical presentation and a careful history taking. Diagnosis is confirmed by CT, which is accepted as the standard method for diagnosis. Other imaging modalities such as the transesophageal echocardiography or MRI can be utilized in cases when the CT is equivocal. Management: initial management of all types of aortic dissection includes blood pressure, which is usually high at presentation, control and strict pain management, followed by prompt referral to specialist management. Surgical options: type A or type 1 and 2 dissections. Those involving the ascending aorta usually require surgical intervention. The chest is opened through a median sternotomy and cardiopulmonary bypass is started, with core cooling down to 18 degrees Celsius. The aorta is cross-clamped as high as possible and opened. Cardioplegic solution is infused in the coronary ostia to arrest the heart in diastole. If the intimal tear is present and localized, the ascending aorta is excised with the tear and replaced with a synthetic graft. The distal anastomosis is performed with circulatory arrest. There has recently been attempts to carry out endovascular stenting of type A dissection with variable degrees of success. Type B or type 3 dissections. Initially, these are best managed medically with antihypertensive drugs. Intervention is indicated in complicated cases if the pain increases, signaling impending rupture, or when dissection is associated with evidence of malperfusion, such as organ, limb, or neurological symptoms. The use of percutaneously placed endovascular stents is currently the standard intervention of choice in patients with a complicated type of B dissection, and surgery is only preserved for the rare cases which is not suitable for stenting. We can see over here the computed tomography CT scan for the aortic dissection. And we can see the true lumen and the false lumen. So the dissection of the intimal layer is there as such that we can a single aortic lumen appears to be as two lumen, where one is the true lumen and the other is the false lumen created because of the dissection and the blood entering into the intima. Outcomes: if type A dissection is untreated, the mortality is 50% within 48 hours and 75% within 1 to 2 weeks, whereas patients with type B dissections have a better prognosis. The surgical mortality rate is variable but is around 20 to 25% for proximal aortic dissection. The overall survival rate for patients leaving hospital, regardless of the type of dissection, is around 80% at 5 years and 40% at 10 years. Pericardial diseases: there is a fibrous envelope covering the heart and separating it from the mediastinal structures. This fibrous structure includes a parietal layer and allows the heart to move with each beat. It is not essential for life because it can be left wide open after cardiac surgery without any ill effects. However, there are a number of conditions affecting the pericardium that may present to a surgeon. Pericardial effusion: there is a continuous production of resorption and resorption of pericardial fluid. If a disease process disturbs this balance, a pericardial effusion may develop. If the pressure exceeds the pressure in the atria, compression will occur, venous return will fall, and circulation will be compromised. This state of affairs is called tamponade. A gradual buildup of fluid, example malignant infiltration, may be well tolerated for a long period before tamponade occurs, and the pericardial activity may contain 2 liters of fluid. Acute tamponade from penetrating trauma during coronary angiography or post-operatively may occur in minutes with small volumes of blood. The clinical features are low blood pressure with a raised jugular venous pressure and paradoxical pulse. Kussmaul's sign is a characteristic pattern that is seen when the jugular venous pressure rises with inspiration as a result of the impaired venous return to the heart. Emergency treatment of pericardial tamponade is aspiration of the pericardial space with a white bore needle is inserted under local anesthesia to the left of the siphisternum between the angle of the siphisternum and the rib cage. The needle is advanced into the tip of the scapula into the pericardial space. An ECG electrode attached to the needle will indicate when the heart has been touched. This will relieve the situation temporarily until the cause of the tamponade is established. Penetrating wounds of the heart usually require exploration through a median sternotomy. Emergency room thoracotomy is rarely required. Chronic tamponade is usually a result of malignant infiltration of the pericardium, usually secondary carcinoma from breast or bronchus, or very occasionally uremia or connective tissue disease. Treatment sometimes requires pericardial window between pericardial space and pleural or peritoneal space. So, in figure 54.30, we can see in the diagram A, pericardial aspiration through the subxiphoid region is being done, and in B, the site of the needle insertion for pericardial aspiration is shown, and it has been connected to a ECG wire to detect when it touches the heart. Pericarditis: infection and inflammation may also affect the pericardium. Acute pericarditis usually occurs following a viral illness. Treatment is with non-steroidal anti-inflammatory drugs and bed rest in case there is an underlying myocarditis. Acute purulent pericarditis is uncommon but requires urgent drainage and intravenous antibiotics with attention to the underlying cause. Chronic pericarditis is an uncommon condition in which the pericardium becomes thickened or non-compliant. The heart cannot move freely and the stroke volume is reduced by the constrictive process. The central venous pressure is raised and the liver becomes congested. Peripheral edema and ascites are also features. Treatment is surgical and is aimed at relieving the constriction. Cardiac masses. Cardiac masses can be either thrombus, blood clots, or tumors. Thrombus can be found in patients with a poor left ventricular function or long-standing atrial fibrillation, as well as in patients with proximal pulmonary embolus, either in the ventricles or the left atrium. Cardiac tumors can arise from can either be benign or malignant, which in turn can be secondary from lung, esophagus, breast, etc., or primary. Atrial myxoma. This is the most common benign cardiac mass in adult. Myxomas are neoplasm of endocardial origin and often appear as an ovoid pedunculated mass, most commonly seen in the left atrium 75% of times or the right atrium 20%, and are rarely seen in the ventricles. Myxomas are associated with congenital disorder, Carney complex, in 5% of cases. They usually present with symptoms related to the blood flow obstruction through heart valves or systemic embolization. Treatment is by surgical excision and recurrence rates are usually less than 5%. OA figure 54.31, transthoracic echocardiography, view of the left atrial myxoma is shown. You can see it being pedunculated and mass in the left atrium. Second, rhabdomyoma. This is the most common benign cardiac tumor in children. It usually presents with symptoms related to valve dysfunction or arrhythmias. There are usually multicentric pedunculated masses in either or both ventricles. Rhabdomyoma is associated with tuberous sclerosis in more than 50% of cases. Treatment is usually by surgical excision. Primary malignant cardiac tumors. These are extremely rare and less common than secondary malignancies. They include angiosarcoma, rhabdomyosarcoma, and leiomyosarcoma. Patients usually have advanced disease when they are discovered, and they are associated with poor outcomes even with multimodality treatment, surgery, and chemoradiation. Management of cardiac arrest after cardiac surgery. Introduction. The incidence of cardiac arrest after cardiac surgery is around 0.7 to 2.9% with 70 to 79% survival rates. Ventricular fibrillation, VF, tamponade, and major bleeding accounts for the most common reasons for the arrest. Multiple variables may dictate differences in the management of cardiac arrest after cardiac surgery when compared to other situations. Therefore, the EACTS published guidelines for resuscitation of cardiac arrest post-cardiac surgery, which is summarized below. Cardiac arrest with non-shockable rhythm. Cardiac surgical patients who have a non-ventricular fibrillation or ventricular tachycardia arrest may have tamponade, tension pneumothorax, or severe hypovolemia. Prompt treatment is associated with an excellent outcome. Resternotomy should be performed promptly if correcting the pacemaker and administering atropine fail to resolve the arrest, especially if prolonged period of CPR is needed, which will be better performed by internal massage. Emergency resternotomy for ventricular fibrillation or pulseless ventricular tachycardia. A precordial thumb may be performed if within 10 seconds of the onset of VF or pulseless VT. However, this should not delay cardioversion by defibrillation. If VF or pulseless VT, emergency resternotomy should be performed after 3 failed attempts of defibrillation. Emergency resternotomy. After the identification of cardiac arrest, basic life support according to the advanced life support guidelines should be initiated while preparing for emergency resternotomy. Emergency resternotomy may be required in 0.8 to 2.7% of all patients undergoing cardiac surgery. Emergency resternotomy is a multi-practitioner procedure which should be rapidly performed with full aseptic technique. Preparation for emergency resternotomy. A gown and gloves should be donned in a sterile fashion. The thoracic drape is applied, ensuring that the whole bed is covered. If an all-in-one sterile drape is used, then there is no need to prepare the skin with antiseptic. The scalpel is used to cut the sternotomy incision, including all sutures deeply down to the sternal wires. All the sternal wires are cut with the wire cutters. The sternal edges will separate a little, which may relieve tamponade. Suction is used to clear excessive blood or clot. The retractor is placed between the sternal edges and the sternum opened. If cardiac output is restored, expert assistance should then be summoned. If there is no cardiac output, the position of any graft should be carefully identified and internal cardiac massage and internal defibrillation performed if required. Internal cardiac massage. This is a potentially dangerous procedure. Risks include avulsions of a bypass graft with the left internal mammary artery being at particular risk and right ventricular rupture, especially if it is thin or distended. Therefore, it is important to carefully remove any clot and identify structures at risk such as grafts before placing hands around the heart. There are several methods of internal massage. However, the two-hand technique is the safest. The two-hand technique, the heart should be inspected to locate the internal mammary and any other grafts if present, followed by removing any blood clots. The right hand is passed over the apex of the heart and then advanced around the apex to the back of the heart, palm up and hand flat. The left hand is then placed flat onto the anterior surface of the heart and the two hands squeezed together at the rate of 100 per minute. Flat palms and straight fingers are important to avoid any unequal distribution of pressure onto the heart, thereby minimizing the chance of trauma. If there is a mitral valve replacement or repair, care should be taken not to lift the apex by the right hand, as this can cause posterior ventricular rupture. Thank you.